Everyone, welcome to your next test plan lecture. Today we're talking all about health promotion and maintenance. This is going to be a rather large chunk of your test for both RNs and PNs. We're talking 6 to 12%. So the key topics that you're wanting to focus in on: aging process, what are those changes as you get older? Health promotion, disease prevention, so not actually treating disease, but stopping it from ever happening. Screening, high risk behaviors, different lifestyle choices, self-care, how we actually assess our clients. And then we're also going to include here ante, intra, and postpartum care and newborn care. So that's going to be included in your maternity and your L&D lectures, all right? Obviously, there's a whole lot of content there, so those deserve their own lectures. Check those out for all that good stuff. And then you've got your developmental stages and your transitions, your Erickson, your Piaget, so on and so forth. So watch that growth and development lecture for that content. So first key topic, that aging process. If you're lucky, you will age. And there are normal changes that come along with that. First, our vision and hearing do decline. This is not pathologic. It's just a part of getting older. Our strength goes down too, which means we're at an increased risk for falls, and we've got to implement those fall precautions. As well as when we fall, we're at higher risk of our bones breaking since they decalcify. Now, I also need you to watch out on your drug dosage because kidney and liver function decreases the older we get, which means we can't metabolize and we can't excrete those drugs quite as efficiently as we can when we're younger. So they stay in our system longer and longer the older we get. So we got to go down on how much of those drugs we're giving. And lastly, check that skin turgor. The elasticity of our skin goes down with age. All right, this is a huge key topic. If there's one you're really going to zone in on, health promotion and disease prevention should be it. We'll start off with our levels of prevention. In primary prevention, we try to intervene before anyone ever even has an issue. So I try and provide education. I try to immunize somebody. Before you ever have the chicken pox, I'm going to give you that varicella vaccine. Or modify risky behaviors. So let's say someone comes in, they don't wear their seatbelt. I'm going to give them some education and modify that risky behavior. Teach them to wear their seatbelt before they ever get in a car crash. Now, in secondary prevention, we try to early identify the disease. So your classic example of secondary prevention is your screening. Screenings are secondary prevention. We can do this at health fairs, regularly checking blood pressure. So we early identify hypertension when it's in those early stages. We can treat it really, really quickly when it's in those early stages and hopefully stop it from getting really, really bad. In tertiary prevention, we try to treat the disease before we get further complications. So, nutritional education for chronic illness. Maybe a dialysis client needs education about limiting phosphorus in their diet, or outpatient therapy and support groups for clients with mental illness. You see, they already have the disease, they're already on dialysis, but I'm preventing further complications. That's your tertiary prevention. So let's try an NCLEX question about this because I can almost guarantee you're going to see one. An example of a healthcare environment that would provide tertiary care would be an acute care facility, a primary care outpatient clinic, outpatient surgical center, physical rehab center in the community, or a pharmacy. Which one of these settings might you see tertiary care? Care where a client already has an established disease and we are preventing further complications. It's D, that rehabilitation center, right? So somebody already has a chronic disease, a chronic injury, and we are preventing complications like immobility through the use of that rehabilitation. So, with primary prevention, we talked about risk factors and modifying them. These come in one of two flavors: your modifiable risk factors, things that you have the ability to change. Your smoking, your drinking, how you're eating. Maybe you're having a slice of chocolate cake every night. I might fall in that camp, and I definitely have the power to change that. Then you also have your non modifiable, all right? Everyone in my family has high cholesterol. Those are my genetics, and I really cannot do anything about that. Age, ethnicity, sex, something that you are born with and you can't change, that is non modifiable, but it is a part of what puts you at risk for certain diseases. So these do sometimes crop up. Here are some of the ethnicity related risk factors. We see sickle cell anemia more often in African American and Latin American populations. Hypertension, Pacific Islanders, Native Americans, African Americans. You see all of these different potential risk factors. Now, it's not to say for each of these ethnicities you're going to get this disease process. Obviously, that's not the case. But let's say you have a client of European descent that everyone in their family has had cystic fibrosis. You know that they have that ethnicity related risk factor, that genetic risk factor. That's something you're going to screen for. That's something you know they have a lot of risk for. So you're going to include that in your care plan. You're going to use that knowledge of their risk factors to incorporate what you do for them. Another component of your primary prevention is providing that education. So we talked about somebody comes in with that risky behavior, they never wear their seatbelt. Okay, you're going to talk to them about wearing their seatbelt, but how are they going to receive that education the best? Verbal, demonstrating, teach back? Are they a visual learner? You've got to try and assess how that client's going to learn so that you can teach them in an appropriate way. And a lot of our clients have barriers to learning. Maybe there's a language barrier. Maybe they have low health literacy, or maybe they're in a state of stress. We do not learn well when we're stressed. I know when I am really having a lot of anxiety, I cannot receive any learning. You can teach me the most basic thing, it's going to go in one ear and out the other. So try and evaluate what's going on with your client. Is this the best time to educate them about wearing their dang seatbelt? Maybe you need to wait until a little bit later to talk to them about that. Education is not so straightforward. They have to be in a state where they can really learn about it. Now, one of the things we might want to educate about is trying to modify some of these high-risk behaviors. Is the client a smoker? How long have they been smoking? How many packs per day? How about how many drinks of alcohol do they take per day? Are there any illicit substance use? What about sun exposure? I'm particularly concerned about use of UV tanning beds or exposure to the sun without the use of sunscreen. Unprotected sex with multiple partners, those who could be HIV positive or positive for other STDs. Lack of sleep, stress, a sedentary lifestyle, dietary choices. All of these things can impact our risk for disease. And if we can modify that risk before a disease occurs, boom, you've educated your client and performed primary prevention. Last thing for that, primary prevention are your immunizations, okay? Stop someone from getting polio or rotavirus before they ever even get that disease. Now, of course, there are tons of these. We have to give them on a certain schedule, so it can be pretty hard to remember them. Let's try to break that down and make it a little bit easier. At birth, we give Hep B, all right? So just remember B for birth, B for Hep B. Now, at 2 and 6 months, it's going to be the exact same immunizations, okay? And there are 6 of them. So remember, at 6 months, 6 shots, all right? 2 and 6 months are gonna be equal. So you really only have to memorize the same 6 vaccinations. And you can remember they are dripping in Hib and Hep B. Drip, DTaP, rotavirus, IPV, and their PCV13. They're dripping in that Hep B and Hib. So 6 shots, DTaP, Rota, IPV, PCV13, Hib, Hep B, that's their 6 shots. They get that at 6 months, and it's the same at 6 and 2 months. Now, at 4 months old, it's exactly the same, but we minus that Hep B. So they still drip, but only in the Hib. No Hep B at 4 months. And at 12 months, that Hib turns them into a vampire. Vamp, varicella, Hep A, MMR, PCV13. Vamp and Hib. Lastly, in this early childhood vaccination series, we're midway through our early childhood. At 4 to 6 years, we are mid. MMR, IPV, DTaP, mid. And it's a common age to get chickenpox or varicella. So we get our MMR, we get our IPV, our DTaP, and our varicella vaccination. We call those our kindergarten shots. We typically get those 4 to 6 years old. Now, those are the bulk of your vaccinations, and if you get a question on your NCLEX, I bet it's going to come from there. But we do have a few more as kiddos grow up. At 11-year-old, you get your Tdap and your first meningitis shot, and then you get a meningitis booster at 16 years old. It's also really important to know when to start getting that annual flu shot. The answer is 6 months old. It's also important to know which vaccines are live. That means that the component of the vaccine that we're actually injecting, it's alive, and we have to avoid that in certain populations. So if you're immunocompromised, you're undergoing chemotherapy, or have cancer, your body might not be able to handle fighting off the live component of that vaccine. The vaccines that are live include MMR, varicella, rotavirus, and palivuzumab. That's that vaccination for RSV we give to the high-risk infant population. So if any of our clients are immunocompromised, we're going to question an order to give them these vaccines. You can remember which ones are live by remembering there are many vaccines ready to pounce. The MMR, varicella, rotavirus, and palivuzumab vaccines are live. So now let's move on to some secondary prevention, your health screenings. Remember, this is trying to catch something early. So for example, screening for STDs. We recommend this for anyone sexually active. The highest risk, sexually active women that are less than 25 years old. Screening for colorectal cancer. This is recommended for those greater than 50. But hey, if you have a family history, we might want to do this earlier because your risk is going to be higher. Depression screening should be done yearly. This starts at the 12-year-old visit, and we do it with a tool called the PHQ-9. It's a simple little form that you can fill out, sometimes done in the waiting room while you're waiting for the healthcare provider to come in, asks you some questions, and lets that provider know if you're at high or low risk for depression so they can ask you some further questions. Last big one to know for the NCLEX, screening for breast cancer, recommended for women greater than 40. Again, kind of like the colorectal cancer screening, if there's a family history, we might recommend it earlier. Now let's look at a few things the NCLEX calls lifestyle choices. The first being family planning. They definitely want you to know about the different methods of contraception, specifically which ones carry risks and may therefore be contraindicated for certain populations. So a biggie is that oral contraceptions can increase the risk of clotting. So let's say I have a history of a clotting disorder, like I threw a massive PE and I was on ECMO in the ICU a few years ago. Well, then I would not want to be on oral contraceptives. That would really increase my risk of having another pulmonary embolism. No good. I might want to use an intrauterine device. That's not going to be as high risk of causing another clot. All right. Now, a diaphragm. If I have a history of toxic shock syndrome, a diaphragm is not going to be my best choice of family planning. Because it increases the risk for this specific disorder, I'm going to need to go with a different method. Now, another lifestyle choice that you're sure to get a couple of questions on are the various complementary and alternative medicine techniques. You might see this abbreviated CAM, and you really do want to ask about any of these potential treatments or medicines in your health history. So, do you go to the chiropractor? Do you get massage, meditate, biofeedback? And the list goes on. All of these play a role in your client's health. One of the most important are the use of different herbs. So here are some of the common herbal therapies that our clients use. Ginkgo biloba, used for memory, but can cause bleeding as a side effect. Ginseng, used for mental performance enhancement, but can cause bleeding risk. And saw palmetto, used for BPH, but can cause a bleeding risk. So I lumped those three together at the top. I want you to remember each of them just because that bleeding risk, so important. We really need to ask about them specifically, especially in the perioperative space. If your client's coming in for surgery, if they're having a procedure, if they're a bleeding risk for any reason at all, I want to ask specifically if they're taking any herbs. I want to know for sure that they are not going to increase their risk for bleeding in the operating room because they didn't think to tell you about the saw palmetto that they were taking. Next in our little chart, you see St. John's wort. I would say that's one of the most common herbal therapies I have personally seen, usually used for mental health, depression, maybe to help you go to sleep if you have insomnia, but it interacts with a lot of drugs. Really important to know that it interacts with digoxin. So if I have a client taking digoxin, specifically I ask them, all right, do you take St. John's wort? Are you thinking about taking that? Because we do not want them taking those together. It can cause their blood pressure to go up, can also interact with anticoagulants. So we really want them to avoid that if they're on one of those medications. Lastly, down here, we have licorice extract. And I used to think this sounded so ridiculous. Who takes licorice extract? But it really is sometimes used for ulcers and bronchitis. The thing is, it acts like aldosterone, which means it helps the body to retain sodium and water, which can cause, obviously, the blood pressure to go up. We retain water, more volume, more pressure. And then if we're retaining that sodium, it's in exchange for potassium. So we excrete that potassium and we get hypokalemia. So if we're going to be taking licorice extract, we need to keep an eye on our fluid and electrolyte imbalance. So really educate your clients if they're going to take that licorice extract or eat a whole bunch of black licorice for their ulcers or their bronchitis, that there could see an impact on their blood pressure and on their potassium levels. So the next key topic the NCLEX gives us here is self-care. And I want you to start by assessing your client's ability to actually take care of themselves. And this starts off with, do they have what they need to care for themselves? So let's say they need a raised toilet seat to go from sitting to standing. Like, do they have that? Do they need grab bars? What about their support system? Are they totally isolated? How about their home environment? If they cannot climb the stairs, but their bedroom is on the second floor, that's going to be a major problem. Do they have food at home? Drinking water? Any caregivers at all? What do they actually have access to? That's going to give you a clue about if they are able to perform their ADLs. This, of course, stands for their activities of daily living, which we know are dressing, eating, toileting, ambulating, doing those basic things that we have to be able to do to maintain our independence. Now, some people will be able to continue living at home without assistance, performing their ADLs. Others may really need a lot of assistance to be able to do these. For example, you see down here, we've got a shower chair with grab bars, and we've got that mobile showering wand so that a caregiver can help give a nice, good shower, but that the client can remain seated, and that can be in somebody's home so that they can remain in their home and get a lot of help with those ADLs, but not have to go necessarily to a nursing home. Now, we talk about ADLs a lot when it comes to delegating. Obviously, you're going to get all sorts of delegation stuff in your delegation lecture, but let's just touch on it here for a moment, because ADLs are like the picture-perfect thing to give to the unlicensed assistive personnel. You dress, bathe, eat, toilet, ambulate. But there definitely are some exceptions. Take eating, for example. What if your client has just had a stroke and is having some trouble swallowing? They're going to be at high risk for aspiration, so that's going to require some close nursing assessment, and we don't want to delegate that. So always use critical thinking to decide if you really do want to delegate your ADLs. Don't just automatically throw them off on the UAP just because they're an ADL. Now we have actually assessing our client. In a complete physical assessment, we will be gathering our baseline data so we know how things change, whether they trend up or down, getting a total medical history, surveying the client, and then going head to toe to examine them and get their vital signs. So first up, the history. All of their past medical history, what they've been previously diagnosed with, what their family's been diagnosed with, any medication that they take. And then for females, this is going to include their menstrual cycle, contraception method, and then if they have been pregnant before. Next, you want to do a general survey. So like across the room, you want to look and see kind of what is going on. ABCs, do they have an airway? Are they breathing? Do they have good circulation? Are they doubled over grimacing in pain? Do they look super anxious? You can kind of get a vibe for what they look like, hygiene. Are they dressed appropriate to the weather? Does everything seem like it's okay over there? Or are you walking into a bit of a dumpster fire, if you know what I mean? Not the person, but the situation, right? What's going on in this room? And you can look at their skin integrity. Do we have gaping wounds that need to be immediately addressed? If no, and our general survey says that we're safe, we can proceed to some vital signs, okay? Temp, blood pressure, respers, pulse. These are our normal ranges for our adults. You guys know this. We've gone over this in other videos. You also need to know your normal pediatric vital signs. The general key takeaway is that for heart rate and respers, those numbers are going to start really high with itty bitty babies and gradually get lower and lower the bigger the child is, until for a teenager, they reach their normal adult number. Versus with the systolic blood pressure, we're going to start out low, think little baby, not a lot of pressure, and that pressure gets bigger and bigger and bigger until we get to our normal adult blood pressure. I really don't need you to memorize this entire chart. I know I never did, and I'm a pediatric nurse practitioner, but I do know the average range and the trend. So if you gave me a heart rate for a toddler that was wildly out of range, I would be able to identify if it was normal or abnormal. And that's exactly what the NCLEX expects you to do. Now, after you've obtained vital signs, you're going to start with that head to toe assessment. And there are 4 ways you're assessing your client. You inspect with a visual exam. You palpate for any swelling, pain, lumps, bumps, or discomfort. Then you percuss. This is where we use our fingers to tap and assess what sound that tapping makes. When we hear resonance, this is a nice hollow sound, that means we're hearing air. This would be expected over the lungs. Now, if we hear a flat boom sound, it tells me I'm tapping over something solid, like a muscle or bone. Lastly, if we hear a drum-like sound, that's called tympany, and it tells me I'm tapping over fluid. I would expect that over the abdomen. So what if I get tympany over the lungs? Well, that tells me I've got fluid over the lungs where I would expect air. So I need to do further assessment to figure out what's going on. The last way I assess my client is with auscultation, using my stethoscope to listen. Now, the order of assessment is important. We generally go inspect, palpate, percuss, auscultate. But there's one area that's different, and that's going to be the abdomen. Because if I palpate and percuss over the belly, I might be moving around fluid in the abdomen, and then when I go listen to it, I'm going to be listening to all of that fluid that I've palpated and percussed. So over the belly, we are going to look, listen, and then feel. Everywhere else, I'll do my inspection, look, palpate, percuss, and lastly, auscultate. So let's look more at that auscultation. I generally start in the lungs, go into the heart, and then down to the belly and do all my auscultation at once there. So normally for the lungs, I expect them to be clear and equal. Clear, meaning I hear that air go in and out without any crackles, rails, stridor, wheezes. I don't want any popping. I don't want any whistling. That air should just be passing in through open airways and not making any extra noise. When it makes extra noise, that's called an adventitious sound. And that's what you see listed here. Crackles, which can be rails or rhonchi, stridor, or wheezes. So that's what these sounds are, and it's really what you're listening for. If we have wheezes, that's when our airways get small. They're constricted or narrowed for some reason, so as the air passes through, it makes a high-pitched whistling noise. This can happen in asthma or COPD, and it sounds like this. Next, we have something called stridor. This is also kind of a whistling sound, but it's higher pitched. It's all in the upper airway, and it happens when there is a blockage of airflow in the trachea. So edema, croup, foreign body, or the infamous epiglottitis. Here is what it sounds like. Then we've got the crackles. Now, these can be rhonchi when they're coarse. They can be called rails when they're fine. But basically, this is the crackling, rattling, popping that happens when air is moving through some sort of secretion. So it's not the narrowing that we get with wheezes and stridor. It is the crackling that we get when there are secretions. So think pneumonia, pulmonary edema, bronchitis. Here's what you're gonna hear. After listening to both lungs, I will move on to the heart. our normal heart sounds are S1 and S2. You shouldn't hear anything extra. Remember, the fancy word for extra is adventitious. And our extra heart sounds are S3, S4, and then we can also have something called a murmur. So starting off with just those normal heart sounds. S1 is when your mitral and tricuspid valves close. So those are those atrioventricular valves, the valves between the atria and the ventricles. They close during systole and they make that lub sound. Then after they close, naturally diastole comes next and your aortic and pulmonic valves close. That makes the dub sound. Let's listen to it. If you hear anything other than that nice lub dub, it's extra adventitious. S3 is a sloshing noise that would come after that S2 dub you just heard. It's caused by fluid overload. So think heart failure, or sometimes we hear it at the end of pregnancy. That's a really hypervolemic state. It sounds like Kentucky. I used to think that the whole S3 was the word Kentucky, but no, it's just that end, Kentucky. It's the E. So all three lub, dub, S3, all three heart sounds are now going to make up the word Kentucky, Kentucky. So if you listen to the heart and you're like, hey, it kind of sounds like it's saying Kentucky, you might actually just be hearing S1, S2, S3. Now, if you listen to the heart and it's like, whoa, it kind of sounds like it's saying Tennessee, Tennessee, you might actually be picking up on S4 instead of S3. And that means it's an extra beat that's coming before S1 instead of after S2. Which, I mean, to just you and me listening with our stethoscope, how are we supposed to identify that? That's super hard, right? It's going to take an EKG and an echo to really determine. But they sound a little bit different. S4 is caused by a stiff atria trying to push that blood forward. So think hypertension, aortic stenosis, cardiomyopathy. Those are more likely to cause that S4, where it's going to sound like Tennessee, Tennessee, versus S3, volume overload, is going to sound more like Kentucky, Kentucky. Now, murmurs, that's a whole different story. I put that in blue because it's only sometimes a problem. In kids, murmurs are often benign. All right, in adults, a little bit more rare to have a murmur and it not be a problem. But children oftentimes have benign murmurs that they grow out of. So if you're in a peds rotation and you hear a murmur, don't automatically freak out. Yes, it could be a problem. They could have a heart defect, but it doesn't automatically mean, whoa, big red flag. What it means is that somewhere in the heart, there is turbulent blood flow that's producing an audible noise, a whooshing noise. In adults, most likely it's regurgitation or stenosis that has allowed this whoosh, this turbulent blood flow that we can hear. Let's listen to it. All right, that was a lot whooshier than the quick, crisp lub dub of S1, S2. So if you hear that, think murmur. And anytime you hear one of these extra noises, assess your client. How do they look? Do they seem like they're in trouble? What are their ABCs? How are their perfusion? And that's going to tell you if you're in trouble or not, right? Okay. Now, after you've listened to the heart, you've got one more thing to listen to. Let's go down to the belly. Okay, moving down from the chest to the belly. Remember, this is the one place where we look, listen, and then feel. Everywhere else, we did our look, we palpated, percussed, and then we finished up with that auscultation. But we don't want to do that on the belly. So we look, listen, and then feel. And when we're looking, I really want to look at the shape of the belly. It's best to do that from the side. And you can see in this illustration, by just kind of drawing a horizontal line from a side view, you'll be able to figure out the shape of the belly. Straight across, that's kind of a flat shape. If you see kind of a dip below that line, that's called a scaphoid abdomen. And if the belly kind of curves above that line, that's a distended abdomen. Now, after you've listened, then you'll kind of palpate, see if it's tender, and you definitely want to inspect to see if there are any pulsations. If there are, we are worried about the possibility of an abdominal aortic aneurysm. That is a potential medical emergency, and so I am not going to palpate, I am not going to auscultate, I'm not going to touch it for fear of it rupturing. I'm going to go notify a healthcare provider right away and hopefully get them to an emergency department. We can normally hear about 5 to 30 gurgles per minute. Now, I don't usually sit there and count the gurgles. I hear about 5 and I move along with my assessment, okay? But if you don't hear anything, don't go charting absent bowel tones unless you have truly sat there and listened for a full 5 minutes. You need to listen in all 4 quadrants and then right at the umbilicus. If you truly don't hear anything after a 5 full minutes, at that point you can chart absent bowel tones. Hypoactive, less than those 5 gurgles. Hyperactive, whoa, way more than 30 in that 1 minute that you listened. So now that we've listened to everything, we'll start at the head and work our way down. The head should be normocephalic and atraumatic. So round, symmetrical, everything can move, no lumps, masses, etc. On babies, there's one extra thing to assess, and that is those soft spots where the bones haven't totally fused all together yet. So we call those the fontanelles. They have an anterior or front one right up here, and then one on the back, they're posterior. The anterior one is bigger, and that closes between 6 and 18 months, whereas the posterior one, a little bit smaller, that's going to close up more quickly by about 2 months. So always feel those, make sure they close at the right time, and normally they should be soft and flat. If they're bulging or depressed, that is noteworthy. That should be noted down in the chart. Now we'll look in the ears. Okay, just looking at the ears, they should be symmetrical, not one higher than the other. We want to look to see if they're low set. That can be indicative of certain genetic disorders. And then we want to look inside the ears with our otoscope to find that tympanic membrane. A normal tympanic membrane is pearly gray, and we see a nice bright light reflex. So that's what you can see right here. This is a normal pearly gray tympanic membrane. Over here, you have one that's really red and inflamed. That kiddo has an ear infection. And up here, we have a perforated eardrum. So maybe they went to a concert that was way too loud and it blew their eardrum. Ouch. Now, coming down to the eyes, I want to check out those pupils, make sure they're perla. That means they are equal in size, they should be a round shape, and they should react to light and accommodation. So when I take my little pen light, flashlight, whatever, and shine it bright in their eyes, I should see that it reacts or gets smaller. That's what's going on down here in this quick little video. That person's retina is sensing all that light and constricting their pupil to respond to it, right? If we've got all this light pouring in, My pupil doesn't need to be so big to take in as much light as possible. So it's reacting to that light. That's what we means reactive to light. And accommodation means that now we're going to take that pen light and move it forwards towards the nose. And we should see those eyes come together to focus on that object. So we do those two things and we say, all right, you are Perla. Now we want to check that the eyeballs can move around in all the directions that they are supposed to. I've got a little drawing here to show you all of the cardinal movements. Basically, I just remember to make an H. So we're going to go up and down both ways and then over to the side. And when you go all the way out to the corners, kind of hold it off to the side a little bit, all the way over, and make sure the eye doesn't kind of twitch. That's called nystagmus. That tells us we've got some weak eyeball muscles. So take a look for that. Then lastly, I want to see how good their vision is. And I'm going to use something called the Snellen chart, okay? So they're going to go 20 feet back from this Snellen chart. I know you've seen it. I know you've done it before, right? And we're going to see what line they can read. Most people can read at 20 feet this 20/20 line, and we consider that normal vision. The higher the number, basically the bigger the number on the bottom line, the poorer the vision. So at 20 feet here, this person with the bottom number being 200, they can only read what most people can read all the way back at 200 feet. So they got to get really, really up close. Versus this 20/20 line at 20 feet, they can read what most people can read at 20 feet. So that is considered our normal vision. That's how we check our visual acuity. Now, you might see a few different eye disorders crop up while you're doing that Perla, cardinal gazes, Snellen chart. So be on the lookout for these. First, you might see some cataracts. These are just an opacity of the lens, and they cause cloudy vision. So you see here on top, we've got a normal eye, clear cornea, and then down on the bottom there, look how cloudy that cornea is. When light hits that cloudy cornea, it's not going to go right through to the retina. It's going to kind of scatter, and it's going to make that vision really, really diffuse and cloudy. So a lot of them have surgery to remove those cloudy opacities, those cataracts. And we commonly see some NCLEX questions on post-cataract surgery. So here's a few quick tips for you. After surgery, the client, they should not lift more than 10 pounds. They can do some light household chores, so they can't quite get out of everything, all right? But keep it easy. They shouldn't do anything, basically, that increases that pressure inside their eyes. That's what we're trying to keep low. They don't want to strain, vacuum, lift heavy groceries. It's best to use a cool compressed and acetaminophen for pain because NSAIDs, aspirin, those increase bleeding risk, and that's what we're trying to avoid. After a few weeks, they'll get to that optimal vision. All right, so with cataracts, you see all the damage up here on the cornea. You can also have problems much further down, for example, all the way back in the optic nerve. That's where the problem lies with glaucoma, which causes this peripheral vision loss. See, for example, this is what the vision of somebody with glaucoma would look like. They can see everything in the middle, but the outside world is black. Open angle glaucoma is a chronic condition. Angle closure glaucoma happens suddenly, and this is an emergency. So if somebody comes in, the outside world is closing in around me, this is a characteristic presentation of this angle closure glaucoma, and it is an emergency. The exact opposite type of vision loss happens with macular degeneration. They don't lose the peripheral vision, they lose the central vision. So they get a black spot right in the middle, and it slowly gets bigger and bigger and bigger. They can still see the periphery, but this central vision starts to go away. It's really important to pay attention to these symptoms and exactly how your client describes their vision, because it really will clue you in to what type of disorder they're having. The other major symptom to watch out for is if someone tells you they either see bright flashes or a curtain being pulled over their field of vision. I have seen that one come up on the NCLEX quite a few times. That curtain coming down over their eyes, that means retinal detachment. And that is a red flag medical emergency, because if their retina detaches, it loses blood flow, it dies, and it leads to blindness. So medical emergency, we got to go to the OR. Keep your client on bed rest and prepare them for surgery. Lastly, if your client has had surgery or some sort of trauma, it's possible to see a collection of blood in that anterior chamber of the eye. So almost right in front, even in front of their cornea, you see that blood collect. It's very bright red. It's quite alarming. And we call that a hyphema. So if somebody comes in with that, you'll know exactly what's going on. Okie doke, on to the nose, where luckily there's much less. The number one thing is making sure it is patent. If you can't breathe through the nose, that's a big problem, okay? So I always have my clients put their hand here to occlude one side, make sure they can breathe through the other side, and vice versa. Look for drainage, tenderness, masses. If there is drainage, look for the color, odor, consistency, amount. And look with your little otoscope to just see the turbinates and see if there's any lumps or bumps in there. Once you're done looking up in their nose, then you can take your light and shine it down in their mouth. What's going on in there? Check out their mucous membranes. Are they nice and moist and pink? You can get a good look at their uvula. It should be in the middle. Check out their soft and hard palate. Are there any clefts? Can you see their tonsils? They should be over to the side. They should not be touching. Are they swollen red? Are there exudates? All that good stuff. Now, I don't check all of my clients' gag reflex. If you have a reason, right, if they're sedated, if you're worried about their gag reflex, then you might need to use a tongue depressor to check that gag reflex. Once you've looked all through their mouth, move on down to the neck. And we'll start off with palpating, okay? Palpate the thyroid and the lymph node. Look for masses and swelling. Make sure they can move their neck, move their head. Do they have their full range of motion? Is there any pain? As you're doing your entire assessment, you're looking at your client's skin, okay? It's especially important once you kind of get down to their extremities. So going over the neck and then down the extremities and looking at the back, but really through your whole assessment, be looking at your skin. Is it the right color? Are they pale and mottled? Is it warm or cool to the touch? Is it intact, right? Do they have a bunch of cuts and scrapes and open lesions? Like, what's the story there? You want to know what's going on. One thing to note when you get down to the fingers is their clubbing, okay? This gentleman right here has significant clubbing. So the fingernails are up, and that is what we call clubbing. This is a sign of long-term hypoxia. So this client has been at subpar oxygen levels, maybe in the high 80s, low 90s, for not days, not weeks, months to years, possibly, to cause this level of clubbing. A common reason for this, COPD. It could also be maybe the client had a heart defect that was or was not repaired and they don't oxygenate properly. Maybe they are a smoker and commonly are at a lower oxygen level. Who knows? But for whatever the reason, they have lower oxygen levels. They commonly don't get enough oxygen out to their tissues, and that has caused this symptom of clubbing. Now, continuing on with things to help us assess this circulation and perfusion, I want to look at their pulses. They should be +2 bilaterally. What about capillary refill? I want that to be less than 3 seconds throughout. I want to compare upper extremities to lower extremities. Look at the color and temperature of all my extremities. Let's check that edema. There is some good +4 pitting edema. I do not want to see that. So check my lower extremities to see, do I have good venous return? Am I getting good circulation? Continuing with my chest assessment, we've already listened. Looking at the breathing, I want to make sure I have an equal rise and fall. I also want to just take a look at how hard it is to breathe. We call that work of breathing. So, are there any retractions? Retractions are when muscles other than the diaphragm are used to breathe and are more or less sucked inward because they are just contracting and pulling so hard to literally work to breathe, right? So common like lingo you'll hear is like, oh, they're working really hard to breathe. Like, yeah, they're really pulling. They're using all those muscles to literally breathe. Breathing should not be effortful, right? Another thing they'll use, nose muscles. So obviously they're not aware of this, but usually when you're breathing, your nose is not super duper involved. But when you're working really hard to breathe, you're sucking in these big breaths through your nose and the side of your nares flare outward. So you can see in this illustration how the widening of the nostrils is visible. You can especially see this on babies. If you're having a trouble kind of gauging their work of breathing, watch their nose for 15, 20 seconds. Is it flaring out? Listen to them. Do you hear a grunting effort, a kind of sound that they're making to try and force their lungs to stay open? You'll also see people head bob or push their head forward as they exhale in an effort to keep their airways open. And lastly, tripoding or extending their bodies forward and putting their arms on their knees and leaning into this forward, almost proning position. Remember when we talk about positioning, if you go back to the positioning lecture as a part of basic care and comfort, we say that supine is the worst for respiratory conditions. And the higher you get, the better it is for your lungs to breathe. All right, so head of bed, up, 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 high Fowler's is good. And then we go to that orthopnic position where you're leaning over a bedside table and you're tripoding. That pulls those lungs forward. It makes it easier for them to expand. So our bodies are pretty smart and they'll start to do this. When kiddos come in to my urgent care and they're having an asthma attack, they're leaned over in the tripod position. So watch for these signs. That'll tell you they're having a hard time breathing. Okay, moving down from the chest to the belly. Remember, this is the one place where we look, listen, and then feel. Everywhere else, we did our look, we palpated, percussed, and then we finished up with that auscultation. But we don't want to do that on the belly. So we look, listen, and then feel. And when we're looking, I really want to look at the shape of the belly. It's best to do that from the side. And you can see in this illustration, by just kind of drawing a horizontal line from a side view, you'll be able to figure out the shape of the belly. Straight across, that's kind of a flat shape. If you see kind of a dip below that line, that's called a scaphoid abdomen. And if the belly kind of curves above that line, that's a distended abdomen. Now, after you've listened, then you'll kind of palpate, see if it's tender, and you definitely want to inspect to see if there are any pulsations. If there are, we are worried about the possibility of an abdominal aortic aneurysm. That is a potential medical emergency, and so I am not going to palpate. I am not going to auscultate. I'm not going to touch it for fear of it rupturing. I'm going to go notify a healthcare provider right away and hopefully get them to an emergency department. Okay, last part of your assessment. We make all the way down to the genitalia and rectum. Of course, this is not always appropriate depending on your client, but in a true head to toe, it should be included. So look at the skin and hair for any tenderness, redness, swelling, and ask if they have any complaints. There might be something bothering them, such as discharge, color, odor, consistency, amount. Is there any pain with urination, burning, etc.? For the rectum, we should always evaluate their stool pattern, constipation or diarrhea, any blood in the stool. Checking their rectal tone and asking about tenderness should conclude this part of the exam. And you've completed a head-to-toe physical assessment. There are so many techniques to examine our clients. So let's wrap up this health promotion and maintenance lecture, putting it all together in an NGN item. You're reviewing a client's medical record who is diagnosed with breast cancer. Here's the client. They are a 56-year-old female. Their routine mammogram showed a 2.3 by 4.5 centimeter lobulated mass in her left breast. A diagnosis of infiltrating ductal carcinoma was made following a biopsy. Clinical history. We've got a BMI, 33. She's nulliparous. She has a maternal history of breast cancer. She doesn't drink, non-smoker, takes iron for an iron deficiency anemia. She is positive for HPV and has genital warts. Okay, so we can come back to her clinical history if needed, because remember, on the NGN, you're going to have tabs over on the left with any of that information that you need to answer the question. And then your question is going to show over on the right. So you'll always be able to navigate all of that information. Let's look at our question. For each portion of the clinical history, indicate if it's a risk factor for breast cancer or not a risk factor. So first and foremost, looking at this massive table is just so overwhelming to me. But when I break it down into one line of the table at once and treat each line as a question, it's really not so bad. They're really each just individual portions. So I don't even think of it as a matrix. All I do is ask myself, okay, is a BMI of 33 a risk factor for breast cancer? True or false? True, absolutely. A BMI of 33 is greater than 30, so that's in the obesity category. And obesity does put you at risk for breast cancer. So I click that one and I move on to what I consider the next question. Cross it off my mind. I'm not coming back to it. I'm not changing my answer. In my mind, I'm just literally moving on to a whole new question. My next question is, okay, is the age of 56 a risk factor for breast cancer? Yes or no? Yes. The way I think of this is over 40, we get our mammograms, right? We know that is the age where we are higher risk for breast cancer. So yes, age of 56, risk factor for breast cancer. Check. Okay. Next question. Maternal history of breast cancer. If my mom had breast cancer, does that mean I'm at higher risk of breast cancer? Yes or no? Simple, one question. What do you think? You bet. Absolutely. Family history of the same type of cancer, strong risk for that cancer. I know you guys got that question right. On to the next question. Does having iron deficiency anemia put you at risk for breast cancer? What do you think? Yes or no? Iron deficiency anemia? Risk for breast cancer? No, as you could probably guess, those two disorders are not related. If we have a deficiency in iron, it does not increase our risk for this type of cancer. So that one's not going to be a risk factor. Okay, moving right along on to our next question. Does HPV with genital warts increase our risk for breast cancer? What do you think? That's right. Same answer as above. Not related, not going to increase our risk. Only one question to go. What about being nulliparous, never having been pregnant, never having given birth before? Does that increase the risk for breast cancer? What do you think? Yes, it actually does. And I know that is a tricky one, but women who have never given birth before are at increased risk for breast cancer. It has to do with the estrogen levels that they secrete. So just remember, nulliparous, higher risk for breast cancer. It is protective to have given birth previously. So there you go. You've completed the entire table, just one question at a time. And remember, partial credit, my friends. So if you didn't know that nulliparous situation, now you know it, but you still would have gotten points for all of those risk factors that you did know. So you didn't lose the whole question. Yay! You still got points for everything else. And if you endorsed on this question, we knew exactly how many points we had to pick, right? Because each line you had to pick one. So we knew there were exactly 6 possible answer choices. So you weren't losing points anywhere. You either got 1 point for each line or you got 0 points if you didn't pick the right one. So we picked all of them correctly. We got 4 points. If we had not chosen the nulliparous one right, we would have gotten 3 points. And that's that. All right, so that about wraps up your health promotion and maintenance. Don't forget, you do have to go back to the anti, intra, and postpartum periods. Those are a big part of health promotion. So you've got maternity and L&D lectures to watch a little later on in your study plan. And I do want you to watch the growth and development lecture. Yuck, I know everyone hates going through Erikson Piaget, but I promise it's going to show up on your NCLEX. And don't forget, this health promotion and maintenance, it's worth 6 to 12% of your test. So it's really worth taking the time. You guys did a great job in this lecture. If you need a little more studies, we've always got those small groups for you. You can scan that QR code to see what's available, find time on the schedule that's most beneficial, and you can always give us a buzz. Shoot us an email to nclextutors@archerreview.com. We're happy to let you know what we have, how we can help you the best, and just try to help you sort through things if you're not quite sure what to do. Because this is really hard, but nothing worth it was ever easy. You've got this, and we'll see you back here for your next lecture. Bye.